There are different ways to do things. So when we're talking about taking care of an African American patient, maybe things that we can identify from that group. And even in the group, we may have different things. So an African American person is somebody defined by somebody that has a dark skin color but was born in the United States. Here, we have people that have dark skin, but they were not born here. So they're still classified as African American, but they just got here. So this is why these groups had to be taken care with very much sensitivity. We are not generalizing. We're just trying to avoid, we're trying to learn what the group in general may do. Because of history, this group tend to have a very little confidence on the health care. They have been lied to, they have been neglected by the healthcare by years of history. This is not nothing new. So they have learned that, and when they come in contact with the healthcare, they don't trust many people. So how they do it is they bring somebody with them, somebody that they respect, somebody they trust, that can become kind of that link, kind of ambassador, and usually somebody from their family or from the church. So when we're taking care of African American patients in the hospital, a lot of times the pastor is making decisions with them. The council liaison goes out there, you're being referred to hospice and say, okay, come back tomorrow when my pastor can come here, we can talk about that. So they give them the chance to have that extra layer of trust to come over, okay? Anything that we can do that they perceive as being discriminatory is going to be taking what we think is a higher level because they have been hypersensitive to that because of the whole long history of discrimination. So if they are giving a smaller room than the other guy next to them, they may see that as discriminatory. And we need to understand where they're coming from and how to solve that anxiety. Because if they have 40 people inside of the room, they may need a bigger room. Okay? So understanding where the patient is coming from may help us to meet the patient where they are and help them move forward where we want them to go. Religion is very important. So we need to provide them privacy for prayers and offer them, can I pray with you? Usually my saying in there is, I'm sorry, I don't pray in English, but I'm sure God can understand everything. So you do your thing in English, I'll do my thing in Spanish, and we may get, when you call the phone to say, press 2 for Spanish, so we may get the 2 lines working at the same time. The expression of the pain may vary. So some of them are very stoic, some of them are very vocal in their expression of pain. So there's not a generalization that is valid in there. When we talk about family, their family is an extended family. So it's the person, the wife, the children, the grandmother, the grandfather, the neighbors, the pastor, the people from the church. So we have to involve them. So HIPAA becomes a problem. Because if you're not in the form, I cannot talk to you about patient in room number 10. So we had to be sensitive to that and ask patient in room number 10 or whoever is making decisions for them, who else you want in this form? There may be 10 or 20 people, but we need to ask that open-ended question so we can help with that. The end-of-life care may be delayed because when we talk about the resistant to do what the healthcare system tells them. And the same thing, the reluctancy to remove life support, maybe because they're still religiously based, are expecting for that last miracle. So if God is going to heal me, who are you to unplug me? And they ask you that. They believe that the illness is a mixture of the biomedical next to the divine intervention. So I may have done something bad, and that's why I got the cold, and now it becomes a flu. But if I do something good, that's going to be reversed. So that belief may be involved in there. And some of them may use traditional herbal remedies. And what is the importance of that? It's not that I'm going to tell you not to do it. It's that I need to know what you're actually taking so I can tell you how can interfere in the drugs that we're going to give you. because there's some herbal medications that may interfere with all the medications that we use. So I need to be aware of that. An example, WJ was admitted to the critical care unit with a pneumonia. He was offered an advance directive, but he said, no, God will help me with this illness, so I don't need it. His lung cancer had gone into remission after the radiation, so he thought that God was there helping him. So why are you going to let me sign an order? He believed that the DNR, or advance directive, will represent him giving up on God. So that's what it means to him. If I'm being helped all this time, why I'm going to say, heck, I don't want any more treatment if God hasn't helped me so far? So that will be a betrayal. And that's when some people may see it. Unfortunately, he actually died, and the DNR was never signed. We have to remember that the patient is the one died, it's not us. It's their family who's making the decision, it's not us. When it is our turn, we better do decisions and make decisions for ourselves. We can only give them the information and let them make the decisions with the best information possible we can give them. If we're going to talk about the Anglo-American group, this population tends to believe that independence is a very high value, that privacy is a very high value. So we have a very hard time when grandma tells us, do not call any of my children, even though she's been falling at home, and we find her in the floor every single night. On-call has to go out there to pick her up from the floor. And we're telling her that she needs to call the children, but no, she doesn't want to involve the children on that issue. It's difficult for us to understand from our biased point of view, but that's what she wants. As long as it's safe for her, she's going to make the decisions in her best way possible. And you're not supposed to be expressing your emotions all around. So that's why, people in this building have a very hard time dealing with Dr. Lozada when she walks in singing and yelling and screaming all at the same time, depending on her mood. Because I'm supposed to be under my control, my emotions are supposed to be under control, but I never learned that. And I'm very loud. So that's my bias in there. Regarding to pain, the Anglo-American group may be very stoic, and we see that very commonly in patients that are veterans. They have been trained to avoid emotions. They have been trained, they have been rewarded for being stoic, and may have some other patients that are very, very much okay expressing the pain. So that's why we ask everybody, and we look at everybody, because some patients say, I don't have any pain, okay? And it means different that to say you're having pain. I haven't pain 10 out of 10, and they're walking around with no problem. So we look into other signs. The family structure is very limited in general. But again, when we move to Ocala, we find that families, that even the Anglo-American families here are very extensive. So it's something different. In the group of the Anglo-American people, the people from Ocala are somehow different. And that's how this apply, okay? But usually, if you're going to the doctor, it's you by yourself, maximum you and your spouse, okay? It doesn't become a family affair like any other culture. And husbands and wife may have equal authority in decision-making. So the woman may make the decision whether the husband is in the room or not, unless she's a personality dependent. That's how it's supposed to be for this group. They generally want to know what's going on, so give me the diagnosis, and what's going to happen to me. But they still will delay the hospice care because they want everything done. And because we have the culture that we have the capacity and resources, we're going to use them. That may delay hospice care a little bit. A lot of them may want to be alone by them when they're ill. And you will have these patients that came to the hospice houses because they don't want to be at home bothered by everybody else. They don't want any visitors. They don't want anybody calling about them. And they have made the decision. And some of them have made that voluntary decision, and some of them have made their life to the point that that's what's going to happen to them, okay? They prefer the aggressive approach in their illness, and they also have the idea that diseases are caused of something organic, but they would like to use some other non-traditional medication in the Western medical. And each one of them has a direct shot with WebMed, with Hippocrates, with the PDR. They all know everything that you're telling them already by the time you're telling them. So you have to meet them at the level. I have this thing with patients, as I say, you have 15 different medications you can use. I'm going to give you the list. You're going to search which one you want me to give you, and the next appointment, you'll tell me what medication you want me to give you. Because it's a fantasy that we have as healthcare providers that we tell patients, you're supposed to be doing this, you're not supposed to be doing M&Ms because you're diabetic, and I have the fantasy that they're going to do what I said. That is my fantasy. So if I tell you to take 1 pill, 2 pills, 3 times a day, wait 30 minutes before your meal, standing on your head, you're supposed to do it because I say so. And that is our fantasy, okay? So patients don't do what we tell them. But if WebMed say that, they may do it. So this is their case. This actually was our patient in Legacy House. He was in room 16. He had been going to AA meetings all his life. And there was this woman in the AA meeting that he hated. He didn't like anything at all. But because they were in the same meeting, he couldn't say that. Now we put him in Legacy House because he was requiring pain management, and she came to visit him. And what did he tell her? Get off my face, in different words. And when I walked in, she said, I'm feeling the best in my whole entire life. And I asked her why. Because now that I'm dying, I feel like doing whatever I really, 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 really feel like doing. So I don't want to see this woman. And I told her that, and I feel so good about it that now I'm able to do what I feel like. And he was by himself in there. He was okay with that. Okay? We treated his pain, and he had a very, in our perspective, very good death, comfortable by himself in the room. We may have some of this group, and we had to open ourselves because we are a population that moves a lot, so we're going to be changing with time. So the Asian American people, or people that are Asian American that belong to this group, they value a lot of harmony and avoidance. So this thing that the oncology comes and says something, the primary care says something else, and the social worker says something different, they don't take it well. So when we are going there with different information, what they choose to do is don't do any what they're saying. So you guys kind of come up with an agreement. Why should I be involved in that? Leave me alone. And the more people that you bring to the discussion, the worse it gets. So this concept of family conference with the doctor, they don't take it well. They don't like it. Because why it takes so many people to be involved in my decision? So this, just listen what you had to say and do whatever you feel like. The devotion to family is very strong. So when our patient said, I'm not going anywhere unless my mother can be at bedside, because I promised her that I will take care of her until the last minute, believe me so when I tell you she's going to do it. And she did. Because that's what they believe. Family ties are very strong. If they giggle in your conversation, they may be nervous about what you're talking about. So that may be a sign, not a disrespect for us, but nervousness for them. And when you offer them something, it's polite in that culture to decline. So if you come and say, Dr. if I were Asian American and they somebody offer me chocolate cake, I'm supposed to say no, thank you. Go around, no thank you, until the third time probably say, okay, give me a freaking cake, I'm going. That applies to the pain medications, because when the patients are having pain and you go and say, are you having pain? Would you like something for your pain? And you're supposed to go around and ask again. They don't want to be a bother for anybody. So they believe that that is the polite way of behaving. It's different from us, so we had to go and insist. Their language is neutral, so they don't have a she and a he. So it may be difficult for them to communicate in our English way. we have to respect that. And being stoic is highly valued. So pain is seen as a way of weakness. And so by the time they report a pain 3 out of 10, you have to multiply that by 100 to come to our scale. Okay? And they're still afraid of being dependent on the medications. Family structure is in a hierarchy. So not everybody has the same value in that family, and each one of them will have a way to express that. Elders are rendered as very valuable, and the people that are going to make decisions. So they may look up to them to help them with big decisions. So the 50-year-old that we were talking about may not make a decision until father gets there. Okay? And visiting each other when they're sick is seen as a duty. So if you got sick and I am Asian American, I'm going to show up to your room whether you like it or not, because that's how I see it. They don't like to talk about end-of-life conversations. They try to avoid the word cancer. So when they're talking to each other or they're talking to the practitioners, they may say, I have a growth, I have a lesion, I have something in me that is growing, instead of saying cancer, even though they know the biopsy results. Because if you don't say it out loud, it will never happen. They don't like to see chemotherapy because it's the same thing. If you're taking chemotherapy, you have cancer, you're going to die. So they say, I'm taking a medication for this growth that is in me. That's the way they have learned to deal with their situation. Traditional medicine may be more acceptable for them. And fever, and we were talking about this yesterday, fever may be treated with hot blankets, with hot drinks, for which we have very hard time accepting that. Okay, because we know better. So we have science behind us, and we go and tell them, no, take those blankets away. And it may be a cultural barrier if we come with that bias into that relationship. Mental illness is seen as a stigma, even more so than in our Anglo group. So patients, when they are depressed and they're sad, they're not going to come to the primary care physician and say, I feel down, blue, sad, or anything like that. They're going to say, I have a headache that I cannot explain. I don't know why I have no energy. So acknowledging that emotionally there's a problem is very difficult for this group. Now, I have some knowledge about this group, and so we're going to talk about that. Our personal relationships are very, very important. So if I'm going to my doctor and he doesn't ask me how many kids I have, where's my husband from, where have been before here, I feel that this guy doesn't care about me. So before we even get into the chief complaint, I'm supposed to interact with this person at a personal level. Otherwise, this doctor is no good for anything. The same matter that if you go to if you're attending to a Hispanic patient, they're going to kiss you, hug you, and make you smooshy before you get there. And if you back off, they're going to take that as an insult. When we start using gloves to do physical exams, a lot of the Hispanic patients will take that as an insult. So because what do you think you are, better than me that you cannot touch me? The personal touch is very important to this group. And if I don't take the insulin, I am not diabetic. So the doctor said that I am diabetic and need insulin, but if I don't take it, nothing happens. So if the insulin never made it to my house, diabetes never came to me. Because if I do some preventive medicine, I am accepting that I'm sick, so I may die. So if I don't do it, it's not going to happen. So if I don't do the mammogram, I'm never going to find out I have breast cancer. This is the thing that we get. Patient has not been in the hospital for 10 years. Well, that may mean something good or may mean something very bad. Okay? The expression of pain may be seen as Hispanics, females are very loud and emotional. They're going to express pain this way. So that's why if they're crying in the emergency room, they don't need Dilaudid 2 milligrams IV Q1 hour, they may need just a Tylenol because they're going to cry anyhow, so I'm going to be treating that with something else. And that may bring a huge problem with this patient. In In the meantime, the male is not supposed to be expressing their pain to much of the people, to many of people. So they may say, the wife, go and tell the nurse that I need pain medications, or to the mother, or to whoever is with them. So they're not supposed to be telling the the healthcare provider, that they are having pain. But they're expecting their pain to be treated any other way. This group would like very frequent and extended visits. We have this term in Spanish that is to say, when you come to my house and you don't spend more than 10 minutes, you say, oh, that is a doctor's visit. Because when you visit me, you expect to spend the whole afternoon. 1 hour is not going to do it. We have a lot to gossip. Okay? So the same thing. So when you're interviewing these people, you make sure that you let them know that you can only stay this much for this reason, so they don't get insulted when you leave in the middle of the conversation, because that's how they see it. Okay? You are very good at following the schedule. They are more into, let's give me my attention because I want it. They don't like to talk about emotional issues unless the family is present. Modesty is very important, okay, in general. In traditional wife are going to let the husband make decisions, because he's been making decisions all their life. So he's going to say which house we're going to pick, and when we're going to start medication, and when the CNA is going to be coming here. This is an issue that we have all the time. Some family members want to shield their patient from the terminal illness. And because we in a cultural-based medical health, we believe the patient has the right to know what they're doing, and they have the right to make decisions based on that. And because this family doesn't want Papa to know that he has a cancer that is terminal, because he may give up or he may die because of that, they may shield the patient from that diagnosis. And we have to surface, we have to be in there into these two cultural groups that are in interface. So what I usually do about it, I ask the patient in front of the family how much they want to know. And if the patient says, not much, I will take the family away and say, this is what's going on. Okay? Once I have established who's going to be making decisions when the patient cannot make decisions anymore. You can't do that. We had a patient that was discharged from the emergency room because the family didn't allow the doctor to tell the patient that he has cancer. So the doctor said, if you're not going to do what I say, you get out of here, and discharge the patient against medical advice from the emergency room. And he never knew. We never talked. We took care of this gentleman in his house until the moment he stopped breathing. And we never told this guy, you have cancer. He knew he was dying. He was not stupid. He was coughing up blood. That is not normal. But there was not a need for a conversation. Where I'm heading, this is what it's called. The family knew. We have a family conference in the living room at the door where he was dying, and we didn't have to go there. And we need to respect that, because that's what they are asking. They may not want to come for hospice, because when you go to hospice, you lose all hope, and you're giving up. And if you remove the life support, you may be calling dead. So the removal of life support may be seen as unplugging the patient, we're killing the patient. They may say yes to everything that you say, but they're not going to do it, because we are supposed to be presenting respect to that doctor, to that nurse. You are identified as an authority. When we were kids, we asked, what are we going to be? A doctor, a nurse, or police? Those are figures of authority. So you do what they say, or you tell them, yes, sir, and do whatever you feel like, okay? She came to the hospital complaining of pain because everybody said Hispanic female in pain. Nobody paid attention to her, and her pain actually was something very bad, and she died of it. We had that patient also in the west or south at some point. She had the diagnosis of lupus. She was jumping from one hospital to the other because of severe pain, and her husband was getting into arguments, fist fight arguments with the emergency room because everybody felt that she was drug seeking. And she died of a lupus that ate her alive. And that's a very painful condition. When she died, she was in a morphine pump. She went to Brandley House several times while she was trying to die, in misery. Not this patient, the one I'm talking about. Middle Easterner, we may have to take care of them, and we may know nothing about them, so we need to learn about them before we encounter that care, because they are here. We took care of a Muslim lady probably 4 or 5 years ago, and we were clueless of what we were doing here. So the team went and studied and asked questions before death happened. We just didn't know that they are supposed to be buried immediately. And she happened to die on a Friday at 4:45 p.m. And we had to run with the death certificate here and there and push the funeral home, because by the time we get there, they were going to bury her, period. Whether the death certificate was done or not, they didn't care. They were going to do it. Okay? Do not assume that everybody in this group, in the Middle Eastern group, they're all Muslim, because they have a large population of Jewish people and Christian people as well. In this case, the practitioner also has to present their personal information, meaning that I finished my residency here at this, and that residency. I am prepared this way to be able to take care of you. Is very important to them. Something that may be feeling kind of stuck up or something kind of narcissistic kind of way, they're expecting that from the doctor. Because if they don't have somebody who is proficient on that care, they don't want it. Okay, so you better go there with your credentials. So I am the CNA of Hospice of Marion County. I have been trained to take care of you. Nobody else in the world can take care of your personal needs better than me, because I have been doing this job for this many years and I have been trained to do so. They're expecting that, okay? To trust you giving them the personal care. The females may avoid eye-to-eye contact. And if they are practitioners of the Islam, they may need space and time in their schedule to do the prayers on time. So we are not going to schedule CAT scans or ultrasounds or blood drawn when they're supposed to be praying, because that will interfere with their practice, and they will resent that. And this gesture is very offensive for them. So even the emoji one, okay? For us, that means thumbs up, things are good, everything is okay. For them, doesn't mean the same. Imagine what that means for them? Okay, that's what it means for them. I can read all of you guys' teleprompters. Pain is fear. So because pain is a sign of something is very bad, they may get afraid and they may not want to have it. So please treat it right away. When I report pain, I'm expecting pain immediately in this group. They are very family-oriented. They have large numbers of members in the group, and they will come and stay. So they are prolonged visits. There's one of the documentaries that I usually recommend to see, where the mother, the spouse, the sisters of the patient who was dying were staying in the same room in the hospital. That's how they do it, okay? And we need to accept that. So they were all gowned up because they were contact precautions, and they were all staying around them, and they were there. The president is there in the room. In this group, also the wife may relinquish the decision-making to the spouse. And a male physician may be seen more respectful for them than a female, okay? And I will have to suck that up, it will be my turn. They may also want to shield that person from the terminal illness. They may not want to discuss end-of-life care because they are professing their faith. This is not going to happen. So if I pray hard enough, I'm not going to die. If I pray hard enough, the cancer is not going to take me. So why are you talking to me about funeral arrangements? So what you can do, well, talk to somebody else in the family, to the children, to see what else. If not, just let it be. We'll deal with that later on. They may accept hospice care, but at home. You're not going to take them to the hospice house because you're not going to be able to fulfill their needs, no matter what you try. So we had to accept that we had to arrange crisis care and go with them home, okay? Ramadan may impact their compliance with diet and medications. So imagine we write insulin, check insulin before breakfast, and they don't have breakfast, lunch, or dinner. So where are you going to check your finger stick? Can you get your insulin that time? So we had to accept that as well. They see the idea of the injectable medications are more effective than oral medications. So if they want something immediately, better indicate for that IM or IV injection. An evil eye is important. So they have these signs that they wear that you are not supposed to be taking away from them. There's some kind of jewelry they wear to protect from evil eye. And if you remove that because you're going to do an x-ray, you better explain that to the patient, and then you're going to take the x-ray, and immediately after you're going to put it back on because it's important for them. Or tell them to hold it in their hand while they're doing the x-ray of the chest. So give them an option because it's important for them. Now, if you go to visit at home and they offer you some food, better take it, even if it's in Tupperware, and take it with you home, because if you refuse that, it's seen as an insult. So in this case, the spouse, the female is in the hospital and they're trying to do some lab workup and the husband is refusing, because that will mean that somebody's going to touch her skin, somebody that is not him. So the hospital went around, covered her absolutely all over, except the area where the skin was going to be touched for the IV puncture, and they have a female doing the lab workup. Okay, so they are accommodated their needs. Native Americans is a group that we may get to treat every so often, and they come, we take care of them, and we want to make sure that we understand where they're coming from so we can provide with the care that they are expecting from us. They try to communicate in anecdotes and metaphors. So you ask them straightforward, what do you have to eat today? Well, the day went by and I was sitting out there and they went around and they don't tell you that they haven't had any breakfast. And you're not supposed to be rushing them. Hey, I need you to tell me if you have something to eat or not, because I have to keep going, because that's seen as an insult. Being loud and giving a firm handshake may be also seen as insulting to them, because that is seen as aggressive. So in all culture, when you're going to hand your hand for a handshake, you're supposed to be firm. The culture, they don't like that. And we are interfacing all the time, okay? And when you talk about people that had died, you're not talking about their by names. You're talking about their wife, their spouse, their mother, their father, but you're not talking about Michael, John, or White Horse or anything like that. You had to talk about their relationship, but not by the name, because it's insulting to name a deceased person by their name. Stoicism is usual. Pain is mentioned, but not directly expressed. So you ask them, are you having any pain? Mm-hmm. Where? You had to go in deep, and where, how big, because they're not going to say, I'm having a pain that is 7 out of 10 here on my right side. They're not going to do that. And we may see that as somebody that having no pain at all, okay? Extended family is important, and generally patients like to make their own decisions. So doctors are not going to be making decisions for them, family is not going to do it for them. Same thing, terminal diagnosis, end-of-life care, hospice care is not something they like to talk ahead of time, because if you talk about that, it's going to happen faster. So if we avoid the topic, it will never happen. Some tribes may even avoid the contact with dying people. So when that person is identifying as being actually dying, they may request the person to be removed from their house and go into the hospice houses, because it's not kosher for that person to be around the family. But once a person is dead, they are very loud, and expression of pain and sorrow is going to come. So there's a lot of yelling and screaming and shrieking. And we need to open that window for the soul to fly away. We want to know that ahead of time, because if the patient is dying in the hospital, the windows at the hospital cannot be open because of safety issues. So we may want to express that to the family members and say, listen, he's dying in the ICU, there are no windows in here, how can we solve that problem? And identify the problem, change your attitude, and come out with a new behavior. So do we want to do something else? If the patient is dying, can we move it closer to the hallway? Do something that gives them the opportunity to still be who they are. If you're cutting patients, American Native patients, if you're cutting their hair, you need to ask them what you want to do with that hair after being cut, because that means a lot to them. So we had to be respectful for that. And this bag of medicine, and I don't know if you've ever seen that, there's some Hispanic group that will do that. They have a little bag, and that little bag, there's a lot of ammunition, instruments, little gadgets. They are carrying a little bag and clip on them. So if you remove that, you're exposing them to something evil. You had to let them know, I'm going to do an x-ray of your chest. Can you please put the little bag in your hand or somewhere else? I'm going to put it here while I'm doing the x-ray, so I'll give it back to you. If that thing gets lost in the hospital, they will melt down. And tobacco may be sacred, so they're not going to stop smoking, like a lot of people that I tell them to stop. And traditional healers may be mixed, maybe in the mix of the medical care. So this is a painting from Klimt, an Austrian guy. Did it in the 1900s, I don't remember exactly when. Warren may know. But the point of this picture is that death, who's an ugly guy, comes for everybody. So the nuclear family here, the wife, the child, the grandma, the husband, this other dude here, everybody's going to be picked up by the same death. And that's what we are here for. We are here to provide end-of-life care for anybody and everybody that comes to the picture. We have to be aware of what we're doing and how we're doing it so we can make them feel comfortable while they are dying. And that's the end of my talk. Any questions?